Good morning, ladies and gentlemen, and welcome to this session, Delivering Affordable Cancer Care. I'm Stephen Sacker, and I've been here for a couple of days now, and some of you are probably quite familiar with my style, and if so, I hope you can live with it for yet another session. But if you haven't met me before or seen me at this particular summit, my day job is an anchor, a host of a show on the BBC's World News Network. It's called Hard Talk, and so I'm paid to ask challenging, rigorous questions, to dig a little bit deeper into the topic at hand, and that's what I want to do today. I'm very honest with you from the very get-go of this session. This one matters, or I feel personally invested in, to a degree perhaps that goes beyond all of the others that I've been involved with here, and that's because I very recently lost a very close member of my family to cancer, and it was a horrible experience. And I only mention it because it seems to me that given the prevalence of cancer today, all of us in this room, whether we're healthcare professionals or whatever we are, cancer is a reality, and it's such an emotive thing for so many people. And I just speak from my own point of view, having had a family that was blessed enough not to be hit by cancer for a long time, and having just gone through it, I am so eager to hear this debate about, the latest thinking on how we deal with this terrible disease. We know it is hugely expensive. As cancer becomes more prevalent, the costs go up, the treatments become more expensive, the expectations of the public become higher. Figures are bandied around, I think, 300 billion US dollars is believed to be roughly the cost of cancer care across the world today. In many rich world economies, it represents a huge burden on healthcare systems, in the top three costs incurred by healthcare systems. And this is only going to get worse because the projections, demographically, as we live longer, cancer becomes more and more prevalent in our societies. So if it's hugely expensive and arguably unaffordable now, what does that suggest about the future? That is the sort of scary reality that our panel is going to have to address today in this notion of delivering affordable cancer care. I'm not going to talk for much longer. My main job is to introduce you to a terrific panel and then to just set the debate going. Now, as you are well aware, we're talking off the back of this report, something that I hope you're all going to get access to and to read. It is the report that's the result of months of work by a specially commissioned forum of leading experts in the field who've been chewing over this question of delivering affordable cancer care. The team leader, the chairman of the forum, and our sort of thought leader for today is the first person I'm going to introduce to you, Professor Robert Thomas. He's the Chief Cancer Advisor to the Australian State of Victoria's Department of Health. He has a vast sort of reservoir of experience as a cancer surgeon and researcher. Now I suppose you're a public servant in Australia. You're heavily involved in the search for the right kind of cancer reforms in Australia. I think there's a ministerial task force on cancer in that country, which you're a part of. So Robert brings a wealth of experience to it, and he has been on top of this report from the very beginning. So he's going to give us his take on the report very soon. Now, when Robert's done that, we're then going to get a free-flowing debate going. And to take part in the debate, I want to welcome, and by the way, as I did yesterday, I want you to save some applause for all of these people until I've gone through all of their terrific backstories, and then let's give them a very warm hand. But next to Robert, we've got Dr. Otis Brawley. He's the Chief Medical Officer for the American Cancer Society. He's a Professor of Hematology and Oncology at Emory University. He co-chaired the U.S. Surgeon General's Task Force on Cancer Health Disparities, and he's on a host of national and international advisory boards and committees, all aimed at finding the right strategies to combat cancer. Next to Otis Brawley, please give a very warm welcome to Her Royal Highness Princess Rida, who is the chair of the King Hussein Cancer Foundation. She's held that post for well over a decade now. She's a tireless campaigner and advocate in this fight against cancer. She also, I think, is relevant, and given what I said at the very beginning, it's relevant to say that she's the wife of a cancer survivor. So, this is personal as well. Next to Her Royal Highness, we have Murray Brennan. He's a Kiwi, though you wouldn't necessarily know it, because a little bit of the Kiwi accent has disappeared after a long, long distinguished career in the United States. He's a vastly experienced oncologist, chairman of the Department of Surgery at Memorial Sloan Kettering for an awful long time, until 2006. He's currently director of the Bobst International Center, a past chairman of the American College of Surgeons Commission on Cancer, and a former president of the American Surgical Association. So welcome to you, Murray. Next to Murray, we have Dr. Rashid Bekali. Welcome to you, Dr. Bekali. He's executive director of the Lala Salma Foundation in Morocco. And just one word on Dr. Rashid. He would like, he understands perfectly English, but Dr. Rashid would like to address us in French. So if you have your headsets ready, for those of you who don't speak French, do make sure that you have your translation sets ready. And then at the end of our brilliant panel, please welcome Professor Thierry Philippe, who is president of the Institut Curie, a past president of the French Federation of Cancer Centers, and on the National Cancer Committee in France. So another man with huge experience on this particular topic. So ladies and gentlemen, please give my panel a very warm welcome. So there is an awful lot of expertise on my panel, but I'm also well aware there's an awful lot of experience, insight, and expertise in the audience amongst you guys. So as ever, this is going to be interactive. The idea is that I'll chair the discussion for half an hour or so, and then open it up for a good 40 minutes to Q&A with you guys, because I know already from doing this that some of the best questions and the best thoughts come from the floor. So we've got the roving microphones, and we'll get to that, I promise you. Also, don't forget, there's the app, the Wish 2015 app. You press the buttons, you get to the place where you can ask questions of the particular panels. Get any question you feel like writing down and digitally presenting to me. Do it now, do it whenever you like. I've got a little iPad here, and I will get your questions. So if you don't feel like putting your hand up, but you have got a question, do it that way, and it will get to me, and I'll use it with the panel. So that's pretty much enough from me for now. I'm going to hand over to Robert Thomas just to talk in more detail about the report, and then we'll get the discussion going. So Robert, over to you.
Thank you. Well, thank you very much, Stephen. So Stephen nicely introduced me as Robert Thomas. My wife calls me Robert. My children call me something different. My mother used to call me Robert, but most of my workmates call me Bob. Australians like short, terse names. So for a career progression move, I thought I'd better move to Bob. So for those who don't recognise Robert Thomas, I'm Bob. Let me first start by acknowledging the great support of the Qatar Foundation and the Wish organisation. We've all had a wonderful time here the last couple of days, and I have been incredibly privileged to be part and chosen to be chair of this particular panel on looking at the problem of affordable cancer care. I want to start just by acknowledging the members of that panel. On the platform here, Otis Brawley has been a sterling member of the panel, and I'm grateful to his support. In the audience, I believe we have Leon House from South Africa, and here he is. Leon, yes, thank you. And we will in the report we talk about a project, one of the examples. So the report contains 8 examples of where issues have been dealt with that we talk about in the report to try and get a better outcome for cancer patients. And Leon's ICON network is one which is noted in the report. Raul Marino, I saw down here from Colombia. Raul, thank you for being here. Pradeep Philip, I saw him in the middle here, is from Victoria. He's my boss, actually. And so I sort of put him on the panel just to make sure I got leave to come when it was appropriately needed. Farshad Rahi, I haven't seen Farshad, is he here? Put your hand up, Farshad, if he's here, but he was on the panel and a great support. Al-Qaeda Hareth, he's here, yes, he's a medical oncologist from Qatar and was a loyal supporter of the panel and provided a lot of input into it. And I also wanted to, so I think that's the panel members that are here. I hope I haven't forgotten anybody. I also wanted to thank a particular fellow within the Imperial crowd, Ryan Callahan, who was just a fantastic support. And he and Jodie Geisler, who works in the Department of Health as a policy person, really wrote the report and took the sort of disjointed comments of the panel and made something worthwhile out of it. So I thank both of them for their work. So why cancer? Healthcare is expensive. Healthcare costs are going up everywhere. All healthcare costs are going up, and cancer costs are probably going up more than most other healthcare costs. But cancer is particular. And Stephen, in our little discussion yesterday, told me the story of his brother. And it was moving. It was moving. It affected me. And that still, in the 21st century, so we're in 21st century? Well into the 21st century, an individual as competent and as well adjusted and as well connected as Stephen Sackur has a brother who dies unexpectedly from cancer. And I think it's fair to say, Stephen, without taking your name in vain, that you are still a bit mystified about what happened to him. Why did this happen? What is my risk? What do I tell my family? These are questions which highly intelligent people are still battling with in this time in the history of medicine, and it indicates the issues that abound around cancer. I would guess that everybody in this room has had some contact with cancer, or a cancer patient, or a cancer relative, a cancer workmate, a workmate with cancer, and these are issues which we all have to deal with. Now, Stephen has talked a bit about the cost element. I think costs are important, but I think, as Stephen also indicated, I think we're going to expand the discussion into the issue of value and cancer care generally, and how we can get the optimal program in place which will be cost effective and enable the best outcome for cancer patients. He also mentioned the total burden of cancer is increasing. We have an ageing population. Unfortunately, cancer is more prevalent in the aged group. And there's a new area of interest now called geri-oncology. How do we manage cancer in the older patients? It's a critical, important area. It has impact on costs and outcomes, and we need to work on that effectively in the future. I have an example of geri-oncology in my family. My mother had a lot of heart disease and troubles, and the health system spent millions of dollars on her with her various bits and pieces she had done. But when she was 83, she said to her very gentle, caring, older geriatrician, "I think I've got bowel cancer." He said, "No, you haven't." So she said, "Well, I'm going to ring up a colonoscopist." He comes from a medical family, and if you don't get a colonoscopist, sure enough, she had bowel cancer. So how do you manage a bowel cancer in a person of 83? Because the median age of getting bowel cancer is 71.3 years. So half of them are going to be in that older age group. And I won't go into the full story, but the way our family had to deal with our mother with this cancer, you could fill a book. I won't give you the full story, but interesting and important. So ageing of our population gives us an increased burden of cancer. Interestingly, individual costs of treatment for cancer patients is also increasing. So it's a double whammy. The individual costs of treatment are going up, and the ageing population is giving us a huge impact for cancer costs on our whole system of healthcare into the future. So we've had a number of sessions at this WISH Summit which have talked about costs and about organisation of healthcare systems. So this is a topic, if you like. how do we manage costs in cancer care? How do we make sure that cancer care is optimal? How do we make sure we're getting value in cancer care, whose time has come? It really has come. And so we will, I'm hoping that Mark McClellan is here. Is he here, Mark? There he is. Mark, I'm going to ask him when I finish to say a word about accountable care in relationship to cancer. I will just say that I flew halfway across the world. I went to minus 10 degrees Washington about 3 weeks ago, and I asked Mark, well, tell us about accountable care in cancer. And he gave me a fantastic exposition. But when I came away, I still wasn't sure. So, Mark, this is your moment in a few moments' time. So, cancer is special. So what we did was to look at... let's see if I can change the slide, sorry. So what we did with our particular... Sorry, I've got to feel sort of a bit... someone can just connect me up a bit better. Our report really came down to saying two things. Firstly, there were some root causes which we could identify for possible excess spending in cancer care, and we came up with some policies which we felt we could reduce costs in cancer care delivery and promote value. And they're written up here. Over-treatment, unnecessary interventions. I'm sure we'll discuss this in the panel. Are we diagnosing too much cancer? Are we diagnosing cancers that don't need treatment? Are we treating cancers too aggressively? The issue of disconnect between value and technology adoption. Are we having these fantastic new drugs which we're putting in, which are into the healthcare system, but with very little real benefit for the patient? An inefficient cancer service delivery. Lots of system talk at this particular meeting, getting a better system of care in place for managing cancer patients, manage them in the right place, the right hospital, by the right people, is a key issue for a good outcome and a cost-efficient outcome. And we felt we could, through these policies which are listed there, improve the situation. We need to reduce delivery costs as well as upholding the standards of care. We wanted to, this is a little bit related to the accountable care program, reward patient-centred outcomes and clinician responsibility. We don't do that very much in our current system, but this is a way of managing the patient better through their pathway and getting in a better outcome for lower costs. Ensure patient engagement in personalised care, a very interesting and complex subject. Not clear absolutely what the outcome is. So if you tell the patient this is a very expensive treatment, will the patient say, well, don't waste that money on me? Or they say, well, thank you very much, I want that treatment. So these are all issues which have to be worked through. We mentioned one example about where a tool has been used to enable patients to engage better with a clinician in this area. And informed decision making in the clinical setting. So this is a key issue. So one of the things that we have been very concerned about is understanding the patient pathway. The patients should be managed along an optimal pathway, and that pathway needs to be informed with data, and not only data about outcomes, but data about costs. We don't have that. We don't have that. I challenge anybody to really tell me where you can find good data about the costs along a particular cancer pathway, and we need that to make an informed discussion. So this is the sort of the basis of the report, and the report then goes on and talks about a variety of examples where in most of these areas something's been done to try and improve the situation and make a difference. So I just wanted to slightly change subject. This is towards the back end of the report now, and talk to you about a sort of a roadmap. So we were very keen to not have a discussion, a 1,000-page paper on the cost of cancer care. We wanted to say and accept that there was a problem with costs in cancer care. Okay, there was a cost. What are we going to do about it? And so we put together a roadmap which is something you can think about as you're concerned with costs in your own particular system. Now, I'll just run through this. Facilitate patient involvement in clinical decision-making. I've already discussed that. Develop a consistent and uniform transit for patients through adherence to cost-informed clinical pathways. I've already mentioned that. And eliminate waste by rewarding control and minimisation of duplicative, that's a good word, and excessive spending along the clinical pathway. I'm going to come back to this in a moment. And then there are 3 points here which really don't fit in, but they're sort of extras which you could think about. We desperately need new costing models for drugs. We all, I won't even go into the issue of drug costs. We know that drug costs are enormous. Sometimes the value from those drugs is fantastic. Sometimes the value from those drugs is less than significant. So we need new costing models. And although pay for results for drugs has been tried and has basically been discarded, it perhaps needs to be re-looked at. I've already mentioned accountable care, but we could incrementally introduce accountable care award systems on a jurisdictional and disease basis. This is surely the way to go, paying for outcomes, not for individual items of service. I'll be interested to hear what the panel says about that. But very, very difficult, as we've spoken a lot about in this whole summit, changing the culture, changing the systems, changing the education and of health professionals and making a difference in this area. And the final point, I think, is one which I personally feel very strongly about. We're in the era of genomic medicine. We haven't talked about that very much at this summit, I think, but we are in that era. What we need to do now is to think about what we can get from that era, which is going to save us money. And one thing might be to be able to understand which cancers don't require heavy treatment and which cancers do require heavy treatment. So in the overdiagnosis issue, we constantly find little tiny cancers, prostate is one, breast is another, and we don't know whether they're going to cause damage for the patient or not. We need to be able to work that through so we can say to a patient, look, you have a very tiny breast cancer, but you really don't need to have major surgery, major radiotherapy, major chemotherapy. We can treat you by watchful waiting, if you like. So this is an important area which needs to be put to our genomic researchers and ask them to come up with a simple clinical tool which will enable us to work this through. So this is my final slide, and it's a really important issue. I've already indicated my interest and my desire to see effective clinical pathway programs put in place and patients transferred along that pathway. There's many benefits from this. Most patients don't know what's ahead of them. And most doctors, when they're seeing a patient, don't tell the patient what really lies ahead of them. So just knowing what's ahead of the patient is a good thing. But knowing what's ahead of the patient and doing it correctly and doing it efficiently is cost effective. But to do this, we need to have clinicians engaged. We will not survive. A health system will not survive a change. I heard Pradeep at the session earlier this morning in Accountable Care talking about the problems of dealing with politicians. Now, I've been a surgeon all my life. I've enjoyed that. You go in an operating room, so a surgeon in an operating room, and they're happy. They just shut the door and operate. But when you actually come to dealing with politicians, it's a whole different world. And and politicians will not want a disrupted world. They won't want the hassle and trouble of it. So we have to work out a way of introducing these changes without causing chaos. And one way is to totally involve the clinicians in the program of change. So this is just one thing I thought we could do. Firstly, again, the pathway analysis. Understand the process in the service setting for specific cancer sites and establish evidence-based optimal care pathways for patients. We can do that now. We're doing it at home. And it's incredibly valuable for the health system to have this, for everybody to have that information in hand. And then you can define the variations from the optimal care pathways, starting in high-cost areas. Now, there's been good work done on this in the States, and I mentioned one of them here, which is the ASCO variants, which are basically saying that if you have a particular situation, you do not need to do this or you should do that. But it means that you're having a refined approach to the delivery of care to the patient. And this is the top 5 of ASCO, and a very simple project would be to look at those along the pathway and then plan interventions to address the variants. You'd have to plan the interventions with the clinicians. So this is a project which could be done tomorrow in virtually any health system in the world. And then the really interesting and difficult area is the bottom one: reward cooperative approaches for interventions that result in value and particularly better outcomes for patients. And I don't have an answer to that. It's got to be something more than financial reward. It's got to be something more. It's got to be something to do with changing the culture and the approach of the health professionals. But there must be a way of rewarding and incentivising doctors and other health professionals to work in the best interest of the patient along an agreed pathway. So, Stephen, I think that I'll leave it at that, and thank you.
Well, Bob, thank you very much. Let me invite you to sit down. And what I love about this report is that it comes up with very substantial, specific ideas and recommendations, and I want us to talk about some of them. But I also think we need to talk about where we are now, because to figure out where we go next, you need to really understand what is happening in the system right now. So I'm going to introduce my panel and get everybody to reflect on that for just a moment. Otis Brawley, I want you to tell me, and I tend to ask really blunt questions. I mean, are we right now, particularly in the United States, over-treating for cancer? Are we spending excessive amounts of money and over-treating?
In certain diseases, we are definitely over-treating. In the case of prostate cancer, for example, perhaps 40 or 50% of men with localized prostate cancer should be watched. The majority of men in the United States get aggressive therapy with either radiation or surgery. This concept of overtreatment is difficult for a lot of people. Let me explain. Our definitions of cancer were given to us by German pathologists doing autopsies in the 1850s. They had someone who died. They would do an autopsy. They developed many of the biopsy techniques, mounting tissue on slides, H&E staining, looking at it under a microscope. And they would draw pictures of what cancer was. This is what killed that person. Now today, 160, 170 years later, past this era where we have radiology, where we can image, MRI, ultrasound, biopsy technology, today we can find a 5-millimeter lesion in a woman's breast or a very small lesion in a man's prostate. Send it to a pathologist who does the same H&E staining the German pathologist did in the 1850s. And on that 5-millimeter lesion, today the pathologist says it looks just like what they said killed that patient 160 years ago. Now, the problem is that 5-millimeter lesion may not be genomically programmed to grow, spread, and kill. Yes, it looks like cancer, but maybe it's not going to behave the way we have been taught cancer always behaves. Now, in the United States especially, if a man's told he has prostate cancer, he assumes that it's bad and it needs to be treated. We need to actually start explaining to some folks that in prostate cancer, we can already look under the microscope and say this is a benignish cancer that should be watched.
But this sort of runs against what I feel to be decades of public health messages to populations, particularly in the developed rich world, which say, be more and more aware of cancer, and when you get to a certain age, or if you have a certain family history, you need to be out there getting screened, and you need to be proactive in searching out for cancer. And then if you've got it, the message seems to be you need to deal with it. So you're rewriting all of these sort of attitudinal rules.
Yeah, unfortunately, as science evolves, the rules are going to change, and science has evolved dramatically. And we have to come to grips with and deal with the fact that we need a 21st century definition of cancer, and we're getting it. Whereas for the last 160 years, we've been treating cancer with a mid-1850s definition of cancer.
But let's drill down to specifics. Are you suggesting, take an emotive cancer, a cancer that everybody cares about, breast cancer in women. Are you saying that maybe the public health messages about women getting mammograms and being very proactive in, worrying about breast cancer need to be modified, changed in some way?
Modified, not negated. Breast cancer screening is still very important, still very effective, and still saves lives. And we need to use it with some wisdom. We also need to use treatment with some wisdom. Now, in the case of breast cancer, we've got good data to show that if we treat all the women identified with breast cancer, we will save some lives. We've also got data to show that probably 15 to 25% of those women we treat, we're going to cure unnecessarily.
Really?
Yes. We will save lives by treating everyone. Where the new science needs to go, genomic medicine is going to take us there. In the next 15 to 20 years, I'm going to be able to say, Mrs. Smith, you have a breast cancer, but it's the kind we need to watch. Mrs. Jones, you have a breast cancer, and you need immediate treatment. That's where the science is taking us.
But, we're talking affordability. Right now, you're saying we need to take very seriously the fact that we're actually intervening surgically too often in cases like breast cancer.
Well, in breast cancer, I would still advocate that all women diagnosed with breast cancer be treated because I've got great data to show I do save some lives. In prostate cancer, where the data showing that our interventions save lives are actually not nearly as strong, we've got data to show that some men can clearly be watched at this juncture. Some men probably do need to be treated, and some men in a middle frame perhaps need to be given the option where they make the decision.
Okay, well that's fascinating, and we'll talk more about genomics maybe later. But Your Royal Highness, I want to bring you in, and I'm very aware on this panel we've got a lot of expertise and insight from the rich world, and in particular, the United States, but we need to figure out what this debate means and the implications of it in developing countries too. So, Your Royal Highness, I want you to reflect on the affordability question from the point of view of Jordan.
Is it working?
Yeah, it is. It's on. Don't worry. Yeah, so that's what I want you to do, if you wouldn't mind.
Yes, for sure. Thank you. First of all, I think the issue of affordability in cancer care is a huge issue worldwide. But particularly for the developing world.
Sure.
And of course, Jordan is not immune to that. I just want to, I can give you the model that I'm familiar with. Now, prior to 2001, we can safely say that cancer care in Jordan was inadequate and totally disjointed. So basically, it was only the privileged few who are able to travel abroad for treatment.
There was really no treatment at home?
There was, I wouldn't call it treatment because in cancer care you either get the best or don't bother getting it. So yes, there was care being dispensed, but it certainly was totally inadequate. Now, in 2001, His Majesty appointed me as the chairperson of the King Hussein Cancer Foundation, and the very first thing that was on our mind, the issues that were on our mind was, first of all, how to deliver the most advanced cancer care, and second of all was how to make it affordable. And the way we proceeded to do that was, number one, we espoused a model of not-for-profit, non-governmental institution. And this was important because when you have a not-for-profit institution, profit is taken out of the equation. So as a result, really, everything, all the profit is invested in the interest of the patient. Of course, also being a non-governmental organization, it also removes the bureaucracy that is connected with governments in general, and it gives more credibility and more trust to the center, and therefore allows you to engage with the community and get a big donor base. What we also did was we did a cancer coverage program which was unique to the King Hussein Cancer Center, which is in a way an insurance program, whereby a micro-insurance program, whereby people pay a minimum sum and get cancer coverage. Now, we did it, of course, as an actuarial, and it's a solid program. Now, I'm saying this because in our part of the world, insurance programs do not really have a module that include cancer, which is actually quite shocking.
You mean it's just too expensive to
yeah,
cover?
I mean, you're not insured for cancer.
Right.
Yeah.
I mean, I suppose what I'm thinking already, as we listen to the spiraling costs of the latest 21st technology cancer treatments, and we think about the demands upon the health systems of a relatively poor developing country like Jordan with a limited economic potential, you know, you think to yourself, well, in cost-benefit terms, would the best use of whatever resources you've got in the sphere of cancer be best poured into prevention strategies rather than ever trying to reach a point where you could offer the sophisticated treatment and technologies that you know we talk about in the United States and the West?
Well, you have to attack cancer from every angle. Okay, it's prevention and early detection is a major part of the King Hussein Cancer Foundation, but we have actually succeeded in 13 years in delivering the most advanced cancer care. We have partnerships with the best in cancer care worldwide, be it the NCI or MD Anderson or especially St. Jude's Children's Research Institute. So we have that. We also have accreditation as the only cancer center in the developing world that is accredited by JCO as a disease-specific cancer center. So in terms of advanced care, we were able to deliver that. How were we able to deliver that? We appealed to the Arab brains, basically, in the United States and the West, and to bring them back to Jordan. And they responded positively because, number one, they felt that they had a duty to basically treat their own people, but also because there was an academic environment that was commensurate to their needs. So in terms of advanced care, we succeeded in providing the advanced care. Now, on the other hand, we absolutely launched a nationwide, for example, Jordan breast cancer program. You know, you can't start with everything. You have colon cancer, you have tobacco-related issues.
I was going to say, you could put some serious money into stopping Jordanian smoking.
Yes, yes, absolutely. Smoking in Jordan is very, very high, and it's very sad. And it's not just the cigarette; it's also the argili, which people think that is not harmful. It's actually more harmful than the cigarette. So yes, we are launching that. But the breast cancer campaign we're very, very proud of because we really wanted to move beyond the pink ribbons and the posters and we went all over the kingdom with mobile mammography units by training the technicians who were reading the slides, and as a result, we were able to halve the number of women who came to us at stages 3 and 4 of their cancers, which is the stages where it was too late for them. We explained to them the importance of early detection, and they responded.
Okay, well, thank you so much for that. We'll come back to thinking about ways in which, developing countries respond. Do you want to say something?
Just to say, Stephen, that I perhaps just didn't emphasise this point enough, that the cancer problem in the medium and low resource countries is going to be massive in the next 15, 20 years. It is increasing rapidly. So the cancer issue affects us all. It's not just the high resource countries. And what we were keen to do was to say, well, whatever we're suggesting is something which could be applied in medium and low resource countries. So it's
That was
certainly
an
not.
important
We
point.
certainly didn't take the view that we're only interested in what's happening in,
Sure.
in US NHS.
Right, well, hold the thought, Otis. I just want to bring Murray. I want to get everybody to have an opening thought, and then we're going to make it a free-flowing discussion. But don't lose the thought you've got. Murray Brennan, I seems to me that you, for a lot of your incredibly successful career, were involved at the very, very top end of cutting-edge cancer-fighting technology. You know, Memorial Sloan Kettering is known throughout the world as one of the most brilliant places you could ever be if you've got cancer. You're going to get the best treatment. You're going to get the latest technologies. They're going to have money thrown at your problem. But maybe looking at the way cancer treatment has gone, and certainly the cost issue, do you now feel, it's a weird word to use, but a little guilty about the system that you've been at the apex of for so long?
Well, I think guilt is a religious event. I've had an interesting experience in that I spent my entire professional life working in an amazing institution, delivering what I thought was probably the best cancer care available anywhere in the world. But I did it one patient at a time. So when I decided to stop operating and was asked to consult in various countries and healthcare systems about delivering cancer care, I had to look at the US system. And we were led to believe in the US that it was a problem of access. It's not a problem of access, it's a problem of cost. And why is US cancer care so expensive? Bob and Otis have referred to it. We overdiagnose, we overinvestigate, we overtreat, we treat for minimal benefit, and much more frighteningly, we design reimbursement based on maximizing charge so as to maximize reimbursement.
Did you think that, all of that, which is the most powerful statement, did you think all of that while you were still at Memorial Sloan Kettering?
Absolutely not. I had to reinvent myself because I was delivering cancer care one patient at a time. I just wanted to make a difference. To hell with what it cost, I wanted to make a difference. When I had to start talking to other people in other parts of the world, I began to think, why on earth would I want to export a completely dysfunctional system? And there are solutions to that. And they've been alluded to, and we could go into them, but just one or two examples. First of all, we have a terrible problem with expectation. We rarely, if ever, define for the patient expectation. When I tell a woman that you have an early breast cancer, and I know from prospective randomized trials we can improve your survival and diminish your local recurrence rate. That's true. But what I don't say is, actually, you've got a 90% chance of never recurring, and I'm going to improve that to 92 by additive therapy. I don't say to her, just think about that. What I plan to do, you have a 1 chance in 50 of benefiting. And what I don't say that 50 out of 50 will have the side effects of my surgery or my intervention. That's a failure of expectation. The second thing Otis referred to, and then I'll stop the other panel. I have lots of other ideas. But
No, I don't want you to stop just yet because I'm absolutely fascinated. So just keep going for a bit.
when I started out, I wanted to make a difference. I didn't care. I just wanted to look after that individual, to do operations others couldn't do, to treatments that others, to make a difference for that individual. And then I began to think, well, I needed to gather together data, which I did, wrote many prospective trials, and still I was looking at the far end of the curve. I just wanted to make a difference. What I didn't think about was this idea that some people were never going to recur, or my treatment wasn't going to work. We approve drugs in the United States with benefits measured in days. That's horrendous. So then I began to think, how do I solve that problem? And in fact, you solve that problem not by looking at the end of this brilliant curve that I've been so good at generating. You look at the beginning of the curve. And Otis alluded to that. Genomics is one way, but we already have tools. We already have mathematical models that can take you at your initial cancer and predict your individual likelihood. They're called nomograms, they're called Bayesian kinetics. We already know that we have surrogate markers, that we can treat a person with esophageal cancer that Bob looks after. And if they have a PET scan and it doesn't respond after one dose, drop the drug and change it, because it will not translate into benefit. So the future is looking at the beginning, not the end. And we have multiple other ways to do it. So I've tried to reinvent myself, and I think we should hear from the others.
Yeah. You use the mic, Your Royal Highness, and then, because then we can...
I said, but Sir Murray still believes that Sloan Kettering does deliver one of the best cancer care available.
Why would I stay there if that wasn't so?
Yeah, but it seems to me the big point here is so much of the way cancer care is handled in the United States is, if we are honest about it, about money. It's about the profit motive. It's everybody has an interest in offering the treatments, and you talked about being paid for service rather than outcome. That is the system. It's all about a lot of people making a lot of money out of cancer.
There are no heroes here. They are only villains. The patient's a villain because of unappreciated expectation.
No, but that's
the
not the
doctor's
patient.
a villain.
Not the patient's fault. I don't think the patient's a villain. The patient may be filled with wrong-headed ideas, but the patient isn't a villain.
Absolutely. The patient is one of the villains, just as the doctor is.
Because you mean they refuse to accept
They refuse
the
to
truth.
accept it. We have written papers showing that a woman with early-stage breast cancer, if she has an MRI with that cancer, it does not translate into a single piece of survival or recurrence benefit at the end of 5 years. We've written those papers from our institution. We would be out of business if we didn't offer MRI for breast cancer.
But just before, I just don't think, are you saying that the only way to address the fundamental flaws you see in the US system is to change the entire system, the way it works, the way money works, the way the profit motive drives it?
No, I don't do revolutions.
Thank God.
The reason I don't is women and children get killed in revolutions. The men survive sometimes. What I am saying is that we need to make, and I think Bob has alluded to it, we need to make these decisions based on knowledge, based on education, educating everybody. No, I don't want a revolution. I don't have enough years left to see it out. But I do want us to begin to talk about realistically what we have to offer, and that there is a cost, not just a monetary cost.
All right.
And we've got tools to do it.
Yeah. Well, Murray, thanks for the contribution. I think it's really helped us. Dr. Rashid Bakali, I'm going to ask you, Dr. Rashid, to give us your thoughts. Again, from a different perspective, obviously. I think it's been very interesting to hear Murray and Otis and Bob all critiquing where we're at with cancer care, but obviously talking from first-hand experience in the West. I want you to pick up with the Morocco experience, your perspective. And ladies and gentlemen, we're all going to have to put unless you're a good French speaker, you're going to have to put your translation kit on. So just stand by.
Merci. Tout d'abord, je voudrais remercier les organisateurs.
First of all, I would like to extend all my thanks to the organizers of WISH.
Nous avoir invités à participer
under the chairmanship of Her Highness Sheikh Hamouza bint Nasser for having invited us to take part in this extremely important panel discussion and to speak as the spokesperson, so to say, of African countries, or at least countries of humble revenue. When we started to work in Morocco on the problematic of cancer, we were confronted to a double problem, so to say. First of all, the problematic of access to care, then on the other side, the high cost of handling such cases. And at the same time, there was no proper program of public health that would enable us to work on prevention and early detection. You know that smoking is responsible for 30% of all the cancer. There was a study conducted in Niger to say that the closest doctor is 15 kilometers away, but to have access to a cigarette is only 3 meters. Unfortunately, more and more tobacco producers in developed countries are prospering, and their production is going more and more towards countries with humble revenue, like in Asia or in Africa. So, should we allow this killer or this first global killer free, or shouldn't we start to think about what type of treatment we should offer to those patients? So this is a big public health problem, and this fight should be a global fight integrated in the health systems. From the beginning, we were confronted with the need to take actions that would lead to a global handling and global fight of against cancer and palliative care. For example, let us suppose that we're in a country where there is no health structure. Can we fight cancer? Is it possible? The experience, innovation showed us that, yes, we can do prevention. We can reduce 40% of cancer, or at least avoid them. And we can offer palliative care and not permit or allow people to die with a lot of suffering. Stemming from this reflection in Morocco, we decided, of course not myself alone, but all of us, to have a national plan for fighting cancer. We would like to offer access to care with affordable price. But we, out of experience, know that it is not enough to have a plan in place, but how to have this plan and how to implement it. And this has shown very clearly that when a plan is drafted by all, for all, the public power, the civil society, the private business, health professionals, that I found in the excellent report that was handed to us, this shows that it is the only chance for us to really face this challenge. Everybody should take ownership of this project. People have to be aware of this project and the importance of it, and this is how the national plan in Morocco was able to be put in place and implemented, and this made everything possible. The second thing, when it comes to fighting cancer, is to remain centered on patients, and everybody spoke about this. Every action, every move has to remain patient-centered. What will this give to our patient, to our citizen, especially when the citizen has very modest revenue? I think that this experience can work out in Morocco or in the US, where also a share of the population does not have access to care. Even in the other parts of the world, in countries that have full social security, not everybody has access equitably to all the care needed. This is why I think that the plan can come up with something fundamental. It prioritizes actions to be taken in a country. It allows to set a vision. It allows to organize care and therefore to reduce cost.
May I want to ask you a question because I want to get Thierry in and then we must get to audience questions. But you said something quite early in your comments about the importance of palliative care. And it just seems to me maybe there's a lesson to be learned from countries where you're never going to have your Memorial Sloan Ketterings and the tip-top technologies, you know, that are the most expensive in the world, that extend life chances by a tiny percentage or just give people an extra week or two of viable life. You're never going to be there with the resources you've got. And therefore, maybe there's a lesson to be learned about the importance of palliative care, whereas maybe in the West, in the rich world, talking too much about dying with dignity is seen as the language of losers. You know, we don't really spend too much time doing that because we're not about dying, we're about keeping people alive and alive and alive. Do you think, where you look at it from, in Morocco and from countries that are really economically in a difficult place, that palliative care and dying with dignity is a really important part of an overall cancer strategy?
In fact, yes, palliative care plays a very important role, but I don't think that this is only in countries that have limited revenue. It also applies to developed countries. This is why there is a need. This is why there is a need to reorganize those care, the palliative care. The experience of Morocco is the organization of palliative care at home, and that has been introduced in the primary healthcare system. It is the centers of primary healthcare. It is the neighborhood primary healthcare center that follows and continues the follow-up with the patient at home. This means that we are not only treating the pain, but we are also taking care of those patients, and we are mobilizing the associations operating in this neighborhood around this patient. When we visit on site, we will see this. Maybe the problem is not a problem of treatment, but maybe there are other problems at the same time, meaning if this is a lady who's on her own, if she's a destitute, the neighborhood associations will support her, will help her get up, take care of herself, will help her go to the market, or maybe even cook something to eat. So I think that this solidarity is fundamental. One of the indicators of the plan that has allowed it to succeed is this solidarity. It's this social mobilization, without which, even if we are in a developed country or in a low-revenue country, we will not be able to fight cancer.
Rashid, thank you very much for that. I do want to bring Thierry in now, and then I want to get to questions from the audience. Thierry, you now work with I guess a major research institute. And I wonder, we've had quite a lot of talk about technology and why it is that the costs in the high-end cancer therapies and treatments seem to outstrip even the cost rises that we see elsewhere in the healthcare sector. And also whether there's far too much focus on short-term gains from a lot of the technologies rather than focusing energies on the fundamentals of genomics and other things. Do you think that, I talked about guilt earlier, do you think that the R&D effort in cancer needs to take a share of the blame for the way we see flaws in the treatment system right now?
Okay, first, may I react to two of the previous speakers? First, I want to react to Dr. Brennan, who in fact speak about informed patient and patient preference. I'm a pediatrician, and we are used since a long time to de-escalate trial. We try to reduce things. And when we come to parents and explain to the parents that we can choose, we can random between the 92% survival trial that we know very well and another one that can be less toxic, but we don't know exactly, and so on, they always choose the standard treatment with 92% survival. And it's not so easy to convince patients that you can decrease treatment and offer something different.
Yeah, but that Murray called the patients villains, which shocked me. But Murray's point is that the patients need to be retrained too.
Yeah, but also when you are thinking about a population, it's easy. But when you are thinking about your child, it's more difficult because you want the results, the best possible results now. My second reaction will be about Rachid and the French Cancer Center. We got a cancer plan. We got free cancer plan and progress in cancer, which is obvious in France. However, we still have a lot of inequality, despite the fact that we have a social security, that everybody can afford the treatment. However, a worker in France still have 7 chances more than an executive to got a cancer at 60 years of age. Then let's come back to your question. I think we need to allow researchers to be free of their research, free of their model, free of the way they want to try to understand the way cancer is working. Why? Because we know very well from Marie Curie, when she discovered the radium, she did not have any idea of what can be used in patients with that. Radiotherapy was not known, radiology was not known. Then very often in the politics, the politician comes to the research center and says you should found something that can be useful for the patient. And the correct answer is no. Let the research people try to understand. And the application will come in a second time, never come immediately. When people work on MRI, they don't know at all that will be used in clinics. Then I think this is a very important message. However, we need to try to understand more and more the molecular biology of cancer, because all of your questions may be answered by molecular biology. The molecular biology will not go to personalize medicine, but will allow to know which one of the breast cancer did not need treatment and which one needed treatment. And in fact, what we can expect from molecular biology is to avoid unnecessary treatment, and it's probably the best hope of what you call personalized medicine. But
well,
in fact,
how quick is this coming? I mean, Otis, I think you said, did you talk about the next 10 to 15 years? I mean, you know, the public want this quick. Can you deliver it?
No, it will not be quick. We need to understand. We need trial. 5-10 years, maybe, but no less.
Did you want to say something? And then I'm going to get the audience involved. Either of you two, because you did earlier.
Yeah, if I can. Actually, Dr. Brunel sort of stole my thunder. When we talk about low-resource countries and high-resource countries, I've been to the King Hussein Cancer Center, and I've seen what's going on in Jordan. Let me tell you, I wish we could do that in some areas of Georgia in the United States where I live. There's substantial areas of high-resource countries that are lacking.
Which Thierry was also saying in France. Yeah.
Right. Looking at the King Hussein, listening to the talk this morning about India, many of the answers to this problem of excess in the United States actually can come from countries that have limited resources. I mean, we can learn we can learn from their wisdom. In defense of Sir Murray Brennan, I wrote a book about 2 years ago about the decline of the American healthcare system, and I came to the conclusion at the end of the book that the American healthcare system was going down, and people who were to blame were doctors, nurses, insurers, lawyers, patients, and patient organizations. We have a substantial number in the United States of patient organizations who are actually calling for and mandating excess care, care that is sometimes harmful. I spend a great deal of time doing outcomes research, and I actually can catalog people who get excess care and actually die because they get too much care. We call it iatrogenic death. And the last thing, palliative care is a huge problem worldwide, high-resource and low-resource countries. We have large numbers of people who are in pain, sometimes unwilling to give up treatment and accept palliative care, sometimes not able to get palliative care because it's not available. And I'll end by noting something that's always disturbed me. There are 25 countries in the world where there is no such thing as the legal use of a narcotic. And that means in those 25 countries, palliative care, pain relief for cancer is impossible.
Right. Yeah, that's a thought too. Okay, panel, you've done a great job so far, but you've had the easy questions from me. Now, I'm hoping there's going to be a few real, proper, tough questions from the audience. I've got a few iPad questions too, but I want hands up first, and I want to get as many people. I'm going to take perhaps 3 at a time. So microphone people, if you can get one microphone over for this gentleman over here. We'll take the lady at the front. And we'll start at the front, then move back. So we'll take, if we have a third microphone, do we have a third microphone? No, we don't. That's stretched our resources too far. Okay, so sir, and then you, ma'am. So we'll take 2 at once.
Okay, thank you. Just maybe take you up on a bit of one of the questions you asked, Professor Philip didn't really answer. Is anyone anywhere thinking of taking on the pharmaceutical industry? Is it acceptable for 30,000, 50,000 euros per shot? Is it inevitable if we want research to keep on going, or should we ask pharmaceutical
Is it time to take on the pharmaceutical industry? Look at their priorities in a pretty darn skeptical way.
Well, we did that. In our organization, we did it. A new anti-angiogenic drug was shown to be equivalent to a prior drug approved by the FDA, and the price was 3 times what the other one was. And we wrote to the New York Times saying that we were not going to pay for that drug. I want to make a generic comment. And the generic comment is that all interpersonal relationships, husband, wife, parents, children, doctor, patient, fail because of failure of expectations. If the patient has a greater expectation of what I'm going to deliver than what I can deliver, it will fail. If I set the expectations that I will deliver more than I can deliver, I will fail. I've spent my entire life one-on-one trying to do that.
Trying not to fail, you mean? Or, yeah. I mean, you wouldn't set out to fail, would you? I mean,
deliver. I wouldn't necessarily fail, but if I promise you what I know I can't deliver, or I promise you, go see Otis, he'll take care of you, when I couldn't and he can't, I have failed.
Sure. Ma'am, give us your question.
It works. Est-ce que je peux parler en français?
Okay. C'est possible, oui.
Can I speak in French? Yes, possible. I am Sanda Bakar. I'm a Tunisian journalist. I manage a very specialized group, specialized in health, indeed. I'll be very quick. I thank the Lala Salma Foundation for Morocco for having really underlined this gap between the Western country and the countries that are really suffering from cancer. We are providing opportunities for our schools to be vulnerable to cancer because of the cigarette and the smoking, and mothers do not know what to do while they are warrants for health. We have only 20% of women in Tunisia and in Morocco who breastfeed their babies, while we know very well that this is a good shield against cancer, breastfeeding. Yesterday, we had a very good discussion about diabetes. Although we are talking about cancer here, I can say that one child, a 15-year-old child, was dead in Tunisia because he didn't have $6 when he arrived at hospital, and he didn't have access to care while he had 6 grams of sugar in his blood. And I should underline the role of the media in our country.
I really don't mean to be rude, but do you have a question for the panel?
I'm finishing.
Yeah.
Thank you. Cher monsieur, j'aimerais que
Dear sir,
vous nous disiez
I would like you to tell us how do you see things changing on the ground. Thank you.
Yeah, Dr. Rashid.
Je peux éventuellement parler de notre expérience.
I can talk about my experience, the experience we are having now. This is a very nice experience, and we have the chance to really know this kind of experience. I was saying that we should have a comprehensive approach and that we should work on drafting a plan in order for us to know where we are heading and what we should do and what is the best way to do it. Some lessons learned allowed us to know when we can succeed, potentially. I can talk about the experience of elaboration of national protocols, a protocol of surgery, chemotherapy, etc. But this is a national protocol that is adapted to our situation according to international standards, of course. This allowed us, first, to rationalize expenses. This allowed us also to develop the use generics. And I can give you an example. There is a very known laboratory that used to produce vaccines. When we started, it used to cost $1,100, and now the price is $15 only for a vaccine unit. So the cost, thanks to innovation, can be reduced. We can undertake centralized preparations, and we could reduce it to 25% the use of products. By building specialized centers, by improving quality, we can improve and allow patients and people to have access to care at affordable prices.
Okay, Dr. Rashid, thank you very much for that answer. There was a gentleman here, you've got the mic, but I want to make sure somebody gets the mic. The lady with the pink jacket, so we'll go to you, sir, and then we'll go to you, ma'am, at the back with the pink jacket. So get the microphone, if you would, to the lady, and you give us your question, sir.
Thank you very much for the panel. My name is Harith Al-Khatar. I've been involved with the team preparing for this panel discussion. I have 2 comments and 1 question to the panel.
All right, make it snappy, sir, because we're running out of time.
It's actually a story.
Okay, is it a short one?
Yeah. I'll make it 1 story, and it's a short story, okay? The story is, I had a Moroccan patient, 28-year-old gentleman, who had end-stage cancer. I talked to him about his disease and the treatment options, and all the treatment options were palliative in nature, meaning they're not going to cure him.
Sure.
I emphasized that it's important, quality of life, and for him to go back to his country. He insisted to continue his treatment here. And every time I tried to repeat the message, he should go back to his family. At the end of the day, he told me why he did not want to go back to his country. It was touching. The reason why is he did not want his mother to see him in this condition, and he knew he was dying. And his expectations is that he wanted to die with his mother not knowing it. That was very touching for me. But it raises a very important point, is with regards to more treatment is not better, and I think the panel talked about it, and then patient preference. When you counsel patients for breast cancer and you tell them that chemotherapy benefit is 8%, there are some who will tell you, well, what about the other 92%? And then make a decision that takes into consideration their preferences, opting out of chemotherapy. And I've had that done. So that is one important thing. The other thing is managing expectations in patients who have cancer. We want to keep that hope alive, but at the same time have that frank discussion so that they can prepare for that. And my question to the panel, are we doing our job in educating our patients sufficiently so that they can make those important decisions? Thank you.
Well, that's a good question. Who wants to take it on?
I'd just like to make one sort of illustrative point about this. That is what patients understand and what their expectations are. I remember seeing a patient who was patently dying of their cancer, and the family was shocked when I said to them that the patient was dying, the wife was dying. But they said, they've been told by the doctors that she has stable disease. Stable disease. And they thought that was good. What the doctor was saying, well, you know, it's still there. And eventually something happened. So I'm not quite sure what the answer is and how we do it, but I do believe a really major revision of the way health professionals understand and deal with patients, and equally, as we've heard from Murray and others, an education program for patients so that they really know what's ahead of them. But really, in real politic, I think the answer is to get the health professionals right. So the patients sit there and get the information. So they've got to get the right information, the right tone, the right support, the right degree of sympathy, so that they can make a good judgment and really understand what lies ahead.
What you just said was, tell me how to be a good doctor. And the answer is that an operation is not indicated right now, but I will take care of you.
How many good doctors do you think there are? I mean, you know, are most doctors good doctors in the sense that we're talking about today? Murray?
It's rarely that I'm speechless. I don't know how to answer that question. I do know that if we continue to divide cancer care, we'll have less good doctors. And we have a terrible problem because specialization is here to stay. Patient demands it. But our willingness to give up being a doctor and give care of the patient to multiple different doctors doesn't solve your problem. So somewhere in there has to be a person who says, I will take care of you. And for a surgeon, that's an operation's not indicated, but I will take care of you. Here's my home phone number. They very rarely ever use it, but they know you're there.
Yeah, I mean, I'm just thinking about my own family. That doesn't always happen.
I see the definition of personalized medicine should be this one. The same doctor and the same nurse from the beginning to the end. It's a very important point because
it is a very important point. But
because of the specialization, the change of doctor, they don't know how to speak with one doctor only and take care of you. And I think it's very important. Personalized medicine means you take care of this patient, not the population.
Well, I love the sound of it. I just don't know how often I see it. But anyway,
you can see it, hopefully.
Well, yeah. Now, you know what? I promised the lady over there, and there's lots more questions. Oh, loads more.
Here and also
yeah, but hang on a sec. Whoa, I'm the chairman. I have control, so I'll tell you what I'm going to do. I promised that I would deal with iPad questions too, so at least I'm going to deal with one. There's a question here to Otis. As healthcare providers, Anonymous says, as healthcare providers, we always advocate early detection for early treatment and so better survival. So how can we really modify treatment and consider watchful treatment when at this stage we don't have access to genomic testing everywhere? Won't this run the risk of cancer metastasizing?
Well, you know, as a screening expert, we always want a prospective randomized trial that shows that the screening test actually saves lives. And there are numerous screening tests that we've done over the years where we've assessed them and figured out they did not save lives, sometimes even increased the number of people dying and therefore didn't use it. For example, chest x-ray screening for lung cancer in the 1960s was a net loser.
Because it was actually just...
It actually caused more harm. It actually caused more harm. So the premise of that person is wrong to begin with. We need to look at each individual screening test, evaluate that test, and figure out if it actually causes benefit, and not assume, it's naive to assume, that every screening test that simply identifies cancer actually is beneficial. Some of them have actually been proven to be harmful. The other example I would use would be the urine test for neuroblastoma in children in Japan and Quebec. It was net harmful. It actually increased risk of death by doing that screening test.
Interesting. Okay. I've got two ladies who've actually got microphones in their hands. Yeah, go on. Sorry. Oh, I'm so sorry. Well, yes, of course. Well, let's have, if you don't mind, Your Royal Highness, you ask a question, and then... Oh, it's you. And then I promise we'll keep going, yeah.
Je vais parler en français. Non,
okay.
Désolée.
I will speak in French. I'm sorry. First, I would like to thank Sheikh Hamouza for having invited us and having allowed this to exist. We are here to learn, and I have learned much, believe me. I have always known that there is a gap between developing countries and modest income countries, not only concerning cancer, but also all other diseases. And I'm really surprised today to see that we are sharing problems. We are having the same problems, and this concerns access to care and reduction of costs. Now I can make a proposal or a suggestion, and you will give me your feedback about this. There are experiences that have been made on cancer in Gavi for vaccines and at the World Fund Against AIDS. And this allows people to have general access to treatment. Wouldn't this be a good response to this kind of concern, to have a worldwide solution? Because we are having a treatment delivered in in many countries in Morocco. Can't we have a global response at the global level to this?
Yes, I think you make a wonderful point. I think that the AIDS experience is something which the cancer group can learn from. The expensive drugs were made available through a variety of means, a large amount of money from government, but also a sort of a flexible drug company policy to provide drugs more cheaply. And the administration within low-resource countries was carried out and done. So that there is a lesson there. Within the cancer drugs area, I believe there will be more and more programs in place to try and make drugs available for low-resource and medium-resource countries, which are not the ridiculous price they are in the high-resource countries. Perhaps I can just make a comment about the report. We almost deliberately decided not to get into the issue of why a drug costs so high, because it's a complex issue. It's a governmental industry process, often to negotiate drug prices. It's shrouded in mystery in many cases, and so it's very difficult. But I can tell you that the drug price issue is real. So Gleevec, which was a wonderful drug, used to cost $30,000 for a year's course. And basically the use of Gleevec for the uncommon diseases it's used for has stabilised. So what's happened is the cost of Gleevec has risen to $100,000 per year. So the issue of what a drug company can charge is something which really needs to be dealt with at a very high level.
Are we being ripped off, yes or no, on cancer?
Well, in that situation, I would say yes.
Right.
But there's lots of other elements about this which I'm not really able to make a definite statement about.
Instances where we are definitely being ripped off.
I think there are instances where we are ripped off.
I'm very aware about time, so I promised the two ladies with microphones questions. We'll go for you, ma'am, and then you. We'll take the two questions, and then we'll answer them as briefly as we can.
Mary Gospodarich from Toronto and UICC. I'm a bit disturbed by the direction of this, because I think the bigger problem than delivering affordable cancer care is delivering any cancer care. And I think there's lots of that we know. And I'm somewhat surprised by your, Stephen, rather patronizing statement that Jordan and Morocco will not have Memorial Sloan Kettering following the plenary session where we heard that in India you can have the cardiac outcomes similar to that of Mass General. So I think that we need to change the conversation and consider the investment in cancer as investment in country's economy. There was the whole session in Melbourne at the UICC Cancer Congress to suggest that you actually can save lives, return people to productivity, and that investment in all three aspects, cancer, screening, prevention, early detection, cancer treatment, appropriate high-quality cancer treatment, and supportive care is necessary, and if done properly, it'll actually create economic benefit. So I think we spend a lot of time talking about how expensive cancer care is in the US. Canada is just a little bit north of the border, and for a fraction of the cost has exactly the same cancer outcomes, population-based, and sometimes even better. So I'm not sure we're dealing with the good example, but I worry about the message we're sending to the world here.
Okay. Well, very well put.
Can I just put in a word for prevention of cancer? Tobacco causes, as was noted earlier, a third of cancers. Another close to a third in Western world. This is a huge problem in the developed world. Overnutrition, lack of physical activity, and obesity causes about 30% of cancers in Western Europe and the United States. We need to focus on prevention. When we go to Africa, we need to look at indoor pollution from stoves. We need to talk about hepatitis B vaccine. We didn't talk about HPV vaccine. Cervical cancer screening, which can now be done with visual screening with acetic acid. All of these things are preventatives that are incredibly inexpensive that can prevent a lot of suffering.
Yeah. I want to go to the lady over there. She's been very patient.
Thank you. Elora Finlay, palliative care lead for Wales, but in the UK Parliament I've also been heavily involved in tobacco control measures, which is right the other end, prevention. The model concerns me that we've heard about because it seems to be compartmentalised. And in Cardiff, what we have done is establish hospital palliative care specialist support team completely integrated with oncology. So the oncologist remains in charge of the patient, but the palliative care team is there to support them without a cut-off, so that if treatment is with curative intent, we still may be involved if there's distress and symptoms. If treatment is with palliative intent, we're very likely to have some involvement with the patient, but we've also found we can speed discharge to home, and because of listening to the patient, we're able to help them reset their expectations and goals nearer to reality. And I have a concern in the conversation about educating patients, because I would have to say each one is individual. Each one has individual problems, and whenever we see problems arise, it's usually because the clinicians haven't listened to the message that the patient is trying to tell them, but the professionals have been trying to transmit whatever it is they feel that they want to do. So it's really a plea for how do we achieve integration across the piece so patients don't feel that they're handed on from one to another, but that right from the outset they're aware they're living with uncertainty, and that uncertainty is being faced by everybody in the team, oncology and palliative care and general practice, everyone involved and their surgeons, and that there is an open, honest but gentle conversation to help them live well as long as they can, and then they can die well. But they can't die well unless they've lived well.
I don't know if anybody wants to pick up on that or...
Yeah, I think we should just say that all sounds wonderful and excellent, and I would totally agree with it. It comes back to what I was saying earlier on about understanding the patient pathway, which actually starts right back at prevention, as Otis has just said, but includes every element of care, which should be indivisible from each other, and there should be a smooth program as you go through that sort of pathway.
All right, we're really almost out of time. I ought to take a question, if I can, from the middle section. Do we have a microphone that could get to the middle easily? There's a gentleman. There's two gentlemen in the middle who've got their hands up. If we just get a microphone to you, sir, and then the gentleman behind you, and then I think we're going to have to all break for lunch. But go on, sir, quick as you can.
Okay, I'm the chief medical officer of a major pharmaceutical company, and we created a drug over 12 years ago, which, because it takes time to find how long people survive, our best guess is that people are now living 5 times longer than what they were when we first started our clinical trials. You know, I don't work for Novartis. I didn't develop Gleevec, but right now there are 6 times more people with the disease alive than there were when the drug first went into the clinic. And that's all well and good. But what happens, and this is my own personal experience, with the best of knowledge and intent, we do a trial and we spend $120 million on the trial and it fails. Who pays us back? And it's a problem, which means that we have to go for things. The best disease in the world is something that kills you very quickly because you get an answer very quickly. But if you really want to go for the big diseases where people live 2, 3 years, 4 years, it's extraordinarily expensive.
But
so it's sort of a defense of the way the system works.
Well, I think we're sympathetic to what he says. That it is an issue, and I don't know, I don't think anybody knows, what is the optimal price for some of these drugs. So it is a complex issue.
So we're going to give you, I'm fear this is going to have to be the last question, so go for it.
I'm Dr. Emmanuel Lirica from the African Palliative Care Association. I want to go back to the issue of lessons from HIV and the continuum of care that Baroness has talked about. In Africa, HIV has definitely demonstrated that you can bring down the cost, you can equip health workers to deliver the service, and I think as the African continent, we also need to look even further than that and see if there can be investment on the continent as regards cancer care. Whether it's by the private sector or government, I think the two can work together to do that. Because at the back of that, at the moment, the only country where Africans can go for cancer care without going through the rigors of getting a visa and whether you have a land title to deposit with the embassy or high commission to get the visa is only India. And yet it could be very easy for us to set up a system where we can invest on the continent to have cancer care on the continent to get rid of all these challenges.
Right.
Thank you very much.
No, thank you. Is that going to happen, do you think? You know, are we going to see that kind of investment?
Yeah, I think so. I think it will happen. The level of resource in the low and middle resource countries is increasing. So the Lancet has said by 2030 we'll all be on the same level. And so what we need to do is work out a way of encouraging this earlier. I thought Mary was going to say she wants to have more radiation oncology or radiation therapy machines in low-resource countries. And there are mechanisms, and there's often administrative and other issues which stop them going ahead. So we need to, there's a separate piece of work which says, what can we do to help to make this happen? And I believe it could happen, but there's lots of issues which just sort of prevent it.
All right. Well, ladies and gentlemen, I knew when I set out on this journey that there would be better questions coming from the floor than they could ever come from me, and it's proved to be true. I know I've left questions hanging in the air. I'm really sorry if I haven't turned to you. I'm not going to do a sort of upsum because I think the panel's been fantastic and they've given us so much to think about. I'm going to go away and think about it myself for a little while. It is lunchtime, so let me just thank you for being here, and please give a very warm hand to all of my panel. Thank you very much indeed.